Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 324 of our pharmacotherapy series, which majors in diabetes mellitus. The first question refers to patient PAH from part 323 of this pharmacotherapy series. How should multiple daily insulin injections be initiated in PAH? Many weight-based empiric dose calculations have been proposed for patients with both type 1 and type 2 diabetes. However, these regimens are mostly beneficial for patients with type 1 diabetes because these patients are completely insulin deficient. For patients with type 2 diabetes, initial basal insulin doses that are weight-based or a starting dose of approximately 10 units daily are appropriate options based on patient-specific information. Insulin doses would then be adjusted based on HbG levels. For a basal bolus insulin regimen, insulin glargine, insulin detamir, or insulin degludec could be used as the basal insulin with bolus doses of a rapid or short-acting insulin, e.g. insulin lispro, insulin aspart, or insulin glulisine, given at mealtime. During the initial visit, PAH needs to learn how to inject her insulin, how to test her blood glucose, how and when to test for ketones, either urine or blood, and how to recognize and treat hypoglycemia. She also needs to understand the importance of meal planning and the relationship between carbohydrate intake and insulin action. It is very important not to overwhelm PAH with information on the first visit. One should be particularly sensitive to the psychological impact of this diagnosis on PAH, address her major concerns, and provide only the information that is absolutely essential before the next visit. Between visits, she should be assessed and provided information on an as-needed basis by phone. A reasonable first approach for PAH is to provide a total daily dose of 24 units of insulin, that is approximately 0.5 units per kilogram. Because 50% of the daily dose should be given as basal insulin with the remainder given as rapid-acting insulin divided into 3 doses, PAH would take the following: 12 units of insulin glargine once daily, either in the morning or at bedtime, with 4 units of insulin aspart or lispro given approximately 5 to 10 minutes before each meal. Alternatively, if insulin detamir is used, the dose would generally be split twice daily, that is 6 units twice daily, as the duration of action of insulin detamir is typically less than 24 hours when given at such a small dose. As a caveat, as PAH's glucose concentration returns to normal, glucose toxicity will recede and she may require less insulin. The next question reads, what kind of insulin delivery device should be prescribed for PAH? Insulin delivery is achieved utilizing syringes, pre-filled insulin delivery devices known as pens, or through oral inhalation. Insulin syringes are plastic, disposable syringes with needles that are extremely fine, typically 30 to 31 gauge, sharp, and well lubricated to ease insertion. Pen needles and syringes have been improved so that insulin injections are relatively painless if proper technique is used. The lengths of needles are 15/64 inch, that is 6 mm, 5/16 inch, that is 8 mm, or 1/2 inch, that is 12.7 mm. Research has shown that there is no medical reason why a patient would require use of a needle longer than 4 to 6 mm for insulin administration, as skin thickness does not vary between different demographics. Previous thoughts that larger or obese patients require longer needle length for proper insulin administration have been disproven. Manufacturers produce 1, 0.5, and 0.3 ml syringes for U100 insulin. For patients such as PAH, using fewer than 30 units of insulin per injection, the 0.3 ml syringe is preferred for ease of reading the dose markings on the syringe. Insulin syringes are available in 1-unit increments or 0.5 unit increments. 1/2 unit increments are useful for pediatric patients and for patients who count carbohydrates, because mealtime insulin doses can be rounded to the 0.5 unit. Insulin pen devices are also available for injecting insulin. Pen devices are often preferred because they make insulin administration much easier, especially for patients who need to take their insulin doses away from home. They also can increase dosing accuracy. The pens are particularly useful for patients with A. regimens consisting of multiple daily doses of rapid or short-acting insulin before meals and snacks, such as PAH, B. A fear of needles, C. impaired visual or dexterity problems, D. hectic work schedules or lifestyle, or E. a need to train alternative individuals who administer insulin, e.g., school nurses, or siblings. Additionally, studies have shown that use of insulin pen devices versus vial and syringe insulin administration may result in fewer discontinuations of insulin therapy and improve overall adherence to an insulin regimen. Pens eliminate the need to withdraw insulin, and the insulin dose is dialed up on the device. Pen devices are available as a disposable prefilled pen or a durable pen in which an insulin cartridge is replaced. Most typically used are the prefilled pens which contain a built-in, single-use insulin cartridge. U100 formulations contain 300 units of insulin, whereas concentrated insulins will contain more units in each device. Pen devices are available to dose insulin in 1 unit most and 0.5 unit increments, e.g. Huma Pen Luxura HD. Pen needles are available in 30, 31, and 32 gauge needles and 5/32 inch, that is 4 mm, 3/16 inch, that is 5 mm, 1/4 inch, that is 6 mm, or 5/16 inch, that is 8 mm lengths, but there is no medical rationale to use needles longer than 6 mm. Patients are advised to use a new disposable needle for each injection. Unfortunately, limited health insurance coverage and higher copays may deter pen use. A detailed review of pen devices, both insulin and non-insulin, was published in 2014. For insulin delivery using an insulin pump. If she elected to use a syringe, a 0.3 ml U100 insulin syringe with a short needle length should be prescribed for PAH subjectively. Patients can feel the difference between different brands, or they may prefer the ease of bubble removal, physical characteristics, or packaging of one syringe over another. If she elected to use an insulin pen, a prefilled pen for insulin glargine and insulin aspart or insulin lispro are available. The shortest possible needle length, 4 mm for pen needles and 6 mm for syringes, should be prescribed for PAH. The next question reads, how should PAH be instructed to administer her insulin injections? Regarding injection, PAH should prepare an area for injection. Alcohol swabs may be used to clean the rubber stopper of the insulin vial or pen device. To inject the insulin subcutaneously, PAH should be instructed to firmly pinch up the area to be injected. This creates a firm surface for the injection, and to quickly insert the needle perpendicularly, that is at a 90-degree angle, into the center of this area. Note, however, that if pinching is only necessary, then PAH is using a syringe that is 6 mm or greater. The syringe should be held toward the middle or back of the barrel, like a pencil. Anxious patients have a tendency to choke the hub of the syringe, and this prevents proper needle insertion. A 45-degree angle of injection may be used for infants and very thin individuals who have little subcutaneous fat, especially in the thigh area. The site should not be massaged, because this may accelerate the absorption and onset of action of insulin. When using an insulin pen, the needle should be embedded within the skin for about 5 to 10 seconds after depressing the dosing knob to ensure full delivery of the insulin dose. Regarding the rotating injection sites, the primary sites used for injecting insulin are the lateral thigh, abdomen, avoid 2-inch radius around the navel, and upper arm. The ADA recommends that insulin injections be rotated within the same anatomic region to decrease chances of variability in insulin absorption. Many practitioners recommend using the abdominal area because absorption from this site is least affected by exercise and is the most predictable. Alternatively, PAH can be instructed to rotate her morning injection within one region, e.g., the abdomen, and her evening injection in another anatomic region. This minimizes the variables that can alter her response to insulin. Rotating injection sites also were recommended at one time to avoid the lipodystrophic effect of insulin, lipohypertrophy and lipoatrophy. However, because insulin has been purified, these complications are less common and the importance of rotation is less critical. Nevertheless, repetitive use of the same site of injection may still result in lipohypertrophy, and it does toughen the skin, making needle penetration more difficult. Furthermore, insulin absorption from lipohypertrophic sites can be slowed. Regarding agitation, PAH does not need to agitate insulin glargine or aspart because these are clear insulins. For neutral protamine hagedorn insulin, which is a suspension, or a combination, mixed insulin, the vial or pen must be gently agitated before use. The vial should be rolled between the palms of the hands to minimize foaming. A pen device is inverted back and forth to mix the insulin. Agitation is only required for insulin suspensions, i.e., insulin mixtures. Regarding measurement, first, PAH should make sure her hands and the injection site are clean. She should withdraw the plunger to the level of insulin she intends to inject, e.g., 12 units for her insulin glargine dose, then she should insert the needle into the vial and inject the air to prevent creation of a vacuum within the vial. The vial then should be inverted with the syringe inserted, and 12 units of insulin glargine should be withdrawn. The bevel of the needle should be well below the surface of the insulin to avoid withdrawing air or bubbles into the syringe. Insulin glargine must not be mixed in the same syringe with her rapid-acting insulin, and it should be injected into a different site if it is injected at the same time as her glargine dose. The barrel of the syringe should be held at eye level to check for air bubbles and to allow accurate placement of the plunger tip at the 12-unit mark. If bubbles are present, they should be removed by tapping the syringe gently to coax the bubbles to the top of the barrel, where they can be injected back into the insulin vial. To remove air bubbles in an insulin pen, prime the pen with 2 units of insulin before each use. Repeat until insulin drop appears at tip of pen needle. Also, remove and discard the pen needle from the device in between uses to prevent air bubbles from accumulating. The next question reads, how should PAH be educated to self-monitor her blood glucose? What types of self-monitoring blood glucose tests are available, and what are the major differences among them? How accurate are results obtained from home blood glucose testing? Should she begin continuous glucose monitoring at the same time? The ADA recommends that most individuals with diabetes should attempt to attain and achieve normoglycemia as safely as possible. Self-monitoring of blood glucose is a tool to allow patients to safely achieve these goals. For patients with type 1 diabetes, this can be achieved by the routine use of self-monitoring of blood glucose. Self-monitoring of blood glucose is also important in a. Pregnancy complicated by diabetes. B. Patients with unstable diabetes. C. Patients with a propensity to severe ketosis or hypoglycemia. D. Patients prone to hypoglycemia who may not experience the usual warning symptoms. And E. Patients using an insulin pump. The technology in this area is changing rapidly, with new monitors with advanced features being introduced yearly. All monitors use test strips and are self-timing, requiring no patient action after the blood is placed on the strip. Several factors should be taken into account when evaluating a monitor and its appropriateness for an individual. The primary considerations are ease of use, accuracy relative to a reference standard, reliability, insurance coverage, and cost. Most monitors no longer require coding for the test strips, which simplifies the process for patients. Convenience factors include meter size, volume of blood required for testing, site to obtain sample e.g., finger versus alternative site such as forearm, capacity of the meter to store blood glucose values, that is its memory, and data such as comments, required testing time, ability to download blood glucose values, general availability of strips, ability to turn off audible signals, audible readings and instructions for visually impaired, and availability of technical support. Some devices are less reliable for use in anemic patients, e.g., renal transplant patients, and all function most reliably within certain temperature ranges, usually 60 degrees Fahrenheit to 95 degrees Fahrenheit, and humidity, generally less than 90% conditions. Strips are sensitive to light, moisture, and temperature extremes and must be stored and handled with care. Patient education regarding any testing procedures, the importance of logging results in a diary, and test times are critical. Ultimately, PAH should be taught how and when to check her blood glucose levels in order to optimize her insulin regimen. Used properly, available monitors provide reasonably accurate results that can be used by patients to manage the diabetes. Problems with a monitor can be detected by performing a quality control test once weekly and with each new vial of strips. Anytime self-monitoring of blood glucose values are inconsistent with the patient's symptoms or A1C values, sources of error should be evaluated. PAH's technique should be reviewed periodically, because clinical decisions are often based on the patient's blood glucose testing record. Because PAH is just starting insulin therapy and self-monitoring of blood glucose, it would be reasonable to hold off on considering continuous glucose monitoring until she becomes comfortable with these skills. Then, she and her practitioner could assess whether continuous glucose monitoring would be useful. The next question reads, how often should PAH test her blood glucose concentrations? Although the exact frequency and timing of blood glucose tests should be dictated by individualized patient goals, most patients with type 1 diabetes using basal bolus insulin regimens should perform self-monitoring of blood glucose at least 3 times daily or more according to the ADA. Glucose monitoring should also be performed more frequently if needed, such as when therapy is modified, prior to exercise, when the patient suspects hypoglycemia, after treatment of hypoglycemia, or when the patient is performing a critical task such as driving. Because PAH is being initiated on insulin therapy with the goal of normoglycemia, she should ideally self-monitor her blood glucose 4 times per day, that is before meals and at bedtime, for 2 weeks until the pattern of blood sugar fluctuation can be assessed and adjustments can be made. Motivated patients may continue this degree of monitoring, but it may be reduced to twice daily for patients on long-term insulin. Varying the time of day in which testing is performed will allow the clinician and patient to make informed decisions on how to make adjustments. For those patients who are not using an intensive insulin regimen, such as patients with type 2 diabetes using insulin, there is insufficient evidence as to how often a patient should check their blood glucose due to the decreased risk of hypoglycemia. Instead, patients along with their providers should determine the appropriate frequency and timing to check blood glucose levels in order to best optimize drug therapy and decrease risk for hypoglycemia. The objective of ongoing, frequent blood glucose testing is to determine whether normoglycemia is being achieved, assess effectiveness of drug therapy as well as the impact of meals, food, illness, or exercise on blood glucose levels. Typical times to check blood glucose may include before meals and snacks, 2 hours postprandial, at bedtime and occasionally at 2 to 3 a.m. However, it can be challenging for patients to adhere to such a rigorous regimen. PAH should set her alarm for 3 a.m. 2 or 3 times per week and test her blood glucose. Blood glucose concentrations measured before meals allow patients and clinicians to determine whether the rapid-acting insulin dose is appropriate for the amount of carbohydrate consumed. Fasting plasma glucose levels are used to determine whether the basal insulin dose is adequate, and the 2 to 3 a.m. blood glucose level is used to identify nocturnal hypoglycemia. For example, the blood glucose measured before dinner reflects the action of PAH's pre-lunch aspartate dose on food she has eaten for lunch, as well as hepatic glucose production between meals. Increasingly, patients who use carbohydrate counting with rapid-acting insulins test 2-hour postprandial levels when initiating therapy to enhance proper dosage adjustment. The importance of frequent blood glucose testing in patients newly diagnosed with type 1 diabetes cannot be overemphasized. When blood glucose is tested less frequently than 4 times daily, it becomes difficult to adjust insulin doses based on infrequent readings or to assess patterns in glucose levels, i.e., pattern management. If patients refuse to test 4 times daily, they should be encouraged to test 4 times daily on representative days of the week or to test at different times of the day each day so that a weekly profile can be developed. PAH also should be encouraged to test her blood glucose concentration anytime she is feeling unusual, if she is experiencing hypoglycemic symptoms, or to evaluate the effect of unusual circumstances on her blood glucose concentration, e.g., increased physical exercise, a large holiday meal, final examinations, or a family crisis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 325.